Question number 3. My slide is not moving. Let me check what the issue is. Okay, it's moving now. Sorry about that. Okay. The question goes, a 62-year-old man, known hypertensive, presented to the A&E with history of breathlessness and bilateral leg swelling. His pulse rate was 130 beats per minute, blood pressure 110/60 millimeters of mercury, heart sound 1, 2, and 3. He had bibasal fine crepitations. The registrar on call reviewed and made an assessment of acute heart failure. He gave him 100 milligrams of furosemide with no improvement. After 30 minutes, he gave another 80 milligrams of furosemide and his condition deteriorated. His relatives were angry and said they were taking him to another hospital. The first question is, what did the registrar do wrong? What should he have done immediately? What urgent investigation should he have requested? And what will you recommend to the hospital management or the registrar? Now, what did he do wrong? The registrar gave an overdose of the IV furosemide to the patient. Initially gave 100 milligrams and later now gave 80 milligrams, making a total of 180 milligrams. And he did this within the space of 30 minutes. And that alone is enough to cause deterioration in the patient's clinical state, even given the fact that the presenting blood pressure was 160 milliliters of mercury. Ideally, what he should have done was to give the IV furosemide an initial dose and then monitor the patient and titrate upward. He should have given another dose maybe after 4 to 6 hours or 6 to 8 hours after the first dose by increasing maybe by 20 to 40 milligrams every 6 to 8 hours. And he ought to have also considered urinary output of this patient. And then if the diuresis is not adequate, then you can add metolazone. There should be an add-on to it. And then you continuously monitor the patient until appropriate diuresis is achieved. Apparently, the registrar was ignorant of how to properly manage this case, and he took laws into his hands. Then another thing he did wrong was to take critical decisions regarding this patient's care without consulting with his seniors. I'm sure there should be a senior registrar on call with him or even a consultant on call, but he decided to take the patient's care and take charge of the patient's care without due consultation, especially displaying this degree of ignorance. And then when the deterioration of the patient, when he noticed the deterioration of this patient and the relatives were becoming apprehensive, they wanted to take their relative away from the hospital, he was unable to establish adequate communication with the patient's relative. He didn't know what to do. Apparently, he got stuck. Now, what should he have done immediately? Like I said earlier, he ought to have informed his seniors on call with him so that they can also have an input in this patient's care and manage this patient appropriately. Okay, what urgent investigation should he have requested in order to really determine if this patient has a heart failure or not? So in order to rule out the diagnosis of heart failure, ideally you're supposed to request for BNP and NT-proBNP. In suspected cases of heart failure, this can actually help to determine if actually it's heart failure or not. And usually when the BNP is less than 100 nanogram per liter or NT-proBNP is less than 200 nanogram per liter, you exclude the diagnosis of heart failure. Then other important investigations that he should have requested for was an urgent echocardiogram. Urgent echocardiogram can determine the injection fraction. Usually injection fraction is a very important tool to use to determine how you manage this patient based on if it's a reduced injection fraction, if it's maintained, or mildly reduced ejection fraction. All that can determine the treatment modalities for this patient. Also, an echo can determine valvular defects and other structural abnormalities. And bedside ECG is also an important test, a chest radiograph, and other lab investigations like electrolytes, urea creatinine, a urinalysis, a full blood count, especially when it has already been stated that the patient had bisal crepitations. Then what will you recommend to the hospital management for the registrar? This is quite a tricky one, but I try to deduce based on the resources that I gathered that the registrar should write a formal report about this incident because, well, they didn't inform us about the degree of deterioration of this patient. So I would say it's a near miss. At least the patient didn't die. There are some cases where the patient, the poor management of the patient can even result in patient's demise. So a formal report about what happened, what transpired should be written. And then there should also be a clinical audit. In every hospital, there is an audit department. So there should be an audit of what really happened, what transpired, and then how to mitigate further reoccurrence of this kind of scenarios. So, and then the other one I also noted down was to organize trainings. Apparently, this registrar was not knowledgeable enough, didn't have enough tools to know how to manage a case of acute heart failure. And I know in our various centers, we have had experiences such as this, where a junior doctor, maybe a house officer, a registrar, had made some clinical mistakes, sometimes leading to the demise of the patient, at other times leading to myriads of complications that can affect patients' care. In fact, I had one very, very bad experience, or well, I thank God that I actually came out of that experience. That was like 2 years ago when I was in the accident and emergency attending to new cases. A call came from the ward that there was this patient that had sickle cell and that the patient was in pain. And the nurses came. I just told my husband, please just go. Since they said this patient is in pain, prescribe IM pentazocine, 30 milligrams start. And so because I was so engrossed with the cases that was in the emergency, I couldn't now leave and to go and attend to that case. So the house official actually went to the ward. He now made a prescription. And believe you me, he gave 90 milligrams of IV pentazocine to this patient, you know? And when I asked him, he said he thought that each ampoule is 10 milligrams. So he now presumed that each ampoule is 10 milligrams. So for the 3 ampoules is 30 milligrams, not knowing that each ampoule is 30 milligrams. And so what actually happened that day? This patient immediately deteriorated, became deep sleep, was in respiratory distress, became unconscious. My God, when they called me from A&E, I ran down to the ward. I said, God, what kind of trouble is this? I was shaking. In fact, and now as I saw the patient was already in distress and was already going, the father knew what happened, was pointing his hand to me. Don't allow this boy to die. If this boy dies, you people will know who I am. And he was the only son. So I said, God, I was praying frantically. And I immediately told my registrar, please go and look for naloxone. I called all the drug reps that I knew. We got a place to get the naloxone. And so she drove down, quickly got the IV naloxone. And within 30 minutes, she came back and I gave the IV naloxone in bolus like that. As we were given, that was how this boy came out. He came out of distress. We took out the oxygen cylinder. We took out everything. He became stable. And I breathed a deep sigh of relief. And I know most of us have had 1 or 2 experiences like that. This was just a near miss. Just imagine if this boy had died, what would have happened to the team? I guess that would have been a different story. And that takes us to clinical governance. What is clinical governance? It's actually a framework through which healthcare organizations, primary healthcare, secondary healthcare, tertiary healthcare centers they are actually held accountable for continuously improving the quality of healthcare services to the patient in order to safeguard high quality of care. There are things there I outlined, I underlined, which are very
Hey, Chief, you
important
have
to.
1 more minute.
Eh?
You have 1 more minute, so you just
Oh,
summarize.
okay. So it's majorly focused on delivering healthcare that is safe and patient-centered. And usually it's based on 7 pillars: staff management, there's clinical effectiveness, information, risk management, education and training, audits, patient and public involvement. These are the mnemonic parties. And in clinical governance, when it talks about one of the pillars is patient and public, this ensures that services are available and appropriate for the public. And then you will have to gain public insight by carrying out patient questionnaires and all that. Then you have to also have clinical audits whereby we evaluate standard of existing care against the gold standard. So each time we carry out clinical audits and researching, a standard, we have to compare it to a particular standard to make sure that these standards are met all the time. And from time to time, there's re-auditing to ascertain that there are improvements in our standard of care. And then in risk management, usually there are unfortunate events that happens from time to time. How do we manage it? We have to have a robust system whereby we try to monitor and minimize the risks to patients and staff through reporting and through identify the problems in areas in treatment and follow protocols. And when there are errors, we should be able to rise above those errors, criticize the individual, and more importantly, must learn to prevent a reoccurrence, as in this case. We need to create education and training for members of staff in order to equip them with the adequate knowledge and skills they need in order to ensure best practices. And usually we do that through staff training, residency program, webinars, lectures, conferences, and courses. And there's also information and technologies whereby patients' information are well documented in a database. Effectiveness and research uses aims to ensure that guidelines, standard guidelines are, maintained. We carry out new research, have to inform new guidelines, papers, and ensure that everything meets up to the standards. Then staff management also is important. We have to we have to take note of those staff that are underperforming, help them to improve. Like this registrar, how can you improve his clinical skills? We have to encourage staff to actively participate in the work environment, and also there should be a appropriate atmosphere for staff so that this idea of the staffs are not happy, no good welfare packages are addressed. This can also mitigate the JAPA syndrome. And in conclusion, I want to say that clinical governance creates the structure through which healthcare organizations can ensure quality healthcare services to patients at all times. It encompasses a range of strategies, processes, and policies that are designed to ensure that patient care is of high standard while also fostering a culture of continuous improvement within the healthcare organizations. It ensures that doctors prioritize patient safety. It's very important. Patient well-being and outcomes. We want to have good outcomes in our treatment practices. It also involves implementing rigorous clinical protocols, adhering to evidence-based practices, and actively seeking to minimize the risks associated medical procedures or treatment. Thank you. These are my references.
Wow, thank you so, so much, Dr. Blessing, for that beautiful presentation. Thank you so much. So now we'll take comments and questions from the participants. Okay, and please let's keep the thanks coming on the chat. So Dr. Modo is saying thanks, you brought it home. Dr. Irabotom is saying, if the patient died in the process, what will be the appropriate recommendation for the registrar in question? Okay, that's a question. Do you want to react to that, Dr. Blessing?
Okay. Yes. If the patient dies, that's a very different kettle of fish. It's not only the registrar, in fact, it's the entire team and even the hospital that would be liable for. There are even sometimes mitigations, and there have been cases where doctors have been taken to court where some even have lost their practicing license. These I don't want to mention it, I have seen people lose their license because of things like this. So for this, the registrar, of course, he would have to go through panel. He would he will face query, he will go through panel and all that. But if the patient had died, not only the registrar that will go down, the entire team goes down. And the most unfortunate part of this is the overall head of the unit that will bear the brunt of this, and that's the unit consultant. The unit consultant, if the relative wants to escalate, the unit consultant can even face the risk of being suspended by MDCN, or even losing the license. Even the registrar can lose his license. So it can be that bad. So we all pray that we'll never fall into that kind of danger that would rob us of our practicing license. I don't know if any other person.
Wow, thank you so much. So Dr. Taribi is saying thank you. Dr. Becky Obas is saying thank you. Dr. Blessing, Dr. Wink is saying thank you. Dr. Kalamama, thank you for a great presentation. Dr. Raleigh Omavowari says thank you. Dr. Adobe Obiefina, Dr. Ibinabo, Dr. Paul Enwanta, Dr. Adebimpe, Dr. Lelikan, a lot of thanks on the chat. Dr. Utohan, Dr. Godia, our Chief Dr. Success saying thank you for the amazing presentation. Dr. Yaya, Dr. Yusuf, and a lot of thanks, more thanks. Okay, there are two electronic hands up. Okay, Dr. Kalamama, and then our chief will come in.
Okay, good evening, facilitators, senior colleagues and colleagues. Thank you so much, Dr. Blessing, for a detailed presentation. As Dr. Mamodo said, you brought it home. Okay, I'm just thinking aloud as regards the investigation to be done for this patient. Okay, using the Framingham criteria, already this patient has two major, two minor, of which we can say one major, two minor, or two minor, one major to make the diagnosis. So, like, thinking of an immediate investigation to do, I'm thinking this patient probably must have had a dyselectrolytemia, where maybe this patient is having a hyponatremia or having hypochloremic alkalosis. So from my own angle, I'm thinking this patient is more or less having an electrolyte imbalance. So I was thinking maybe what we should do at that instant, like the immediate investigation we should do for this patient is EUCR or arterial blood gas. Just thinking aloud, what do you think, Dr. Blessing? Because NT-proBNP, I don't know if that's supposed to be the next investigation to be done, because already from the clinical features, it already shows this patient is in heart failure. So I don't know if that's what we should do to address the patient's immediate health issue or challenge at that point in time. I don't know, Dr. Blessing, what do you think, please?
Okay, apart from that NT-proBNP, I felt that the other immediate test that should be done for this patient is an echocardiogram. I didn't really think of this electrolytemia and all that, so I thought maybe, okay, there could also be other structural heart abnormalities that should be sought out for, and also the injection fraction of this patient, which will also help in the management. So I didn't really look at the electrolyte, although based on the IV furosemide that the registrar gave to this patient, that would have also distorted the electrolytes. So
since this is a cardiology section, okay, maybe I'll say ECG to look out for features of maybe hypokalemia or something. Just thinking aloud. I don't know, I stand to be corrected. Thank you so much. That's just my suggestion. Thank you. Thank you.
All right, thank you so much, Dr. Kalama. Okay, Chief, please go ahead. Chief Chitu.
Hello, yes. Good morning, everyone. I just wanted to wade into the issue of what should be done to the registrar. The truth of the matter is the registrar is in training, and yes, there is some knowledge that he should have that should prevent such things like this happening. Okay? So he's supposed to have had the knowledge base to be able to handle or not to get himself in this type of position. Okay. And regardless of how the situation turned out, what happens to the registrar remains the same. Now, what happens to the registrar depends on the context of his error. Yes. For instance, if the error was made as per he was trying to write something down and mistakenly wrote the wrong thing, okay? Meaning he didn't cross-check his work, okay? 2, it could be that he was writing down an instruction and the instruction was something that should have passed through the consultant, right? And he didn't, get the necessary approval or run his ideas to the person that is more senior, whether the senior registrar or the consultant in his unit. Also, it could also be that the person doesn't have the knowledge base to be able to, sort out things. So that has to do with him not improving himself. Now, regardless of the outcome of the patient, whether the patient died or the patient lived or survived the event, the punishment does not change. Okay, the only thing that will change is that there's a higher chance of litigation, but what you're going to do to the registrar does not change. That is why we have indemnity. Okay, and we are insured for making such errors, and of course, in case you're sued. Now, you could even do well and still be sued. Okay, you could be sued on ethical grounds, you could be sued on clinical grounds, so on and so forth. So that's a kettle of fish. Now, what we focus on here is that an error was made in knowledge, because knowing fully well the period of time it takes for the fusemite to act and knowing the complications of giving too much, okay, in this patient's scenario, okay, then, that is what he failed to know. Now, also, given this standard dose of Lasix, as I think Dr. Remigos, if he's around, or other nephrologists here, will point out that we give doses like that in nephrology, but in a different scenario. So the amount of drug given to the patient, it's possible to give a patient that amount, but not in this context. And also, since he had already started with a certain dose, he should have waited for that dose to play out a bit before adding more. But although in some situations, like patients in acute pulmonary edema, okay, sometimes you wallop the person heavy, okay? Maybe started with what he had available and then he added more later on or something. Yeah, fusemide you can go to unreasonable doses, okay, of fusemide. Sometimes you can go well over 200, okay? But how you give it is important. Sometimes you give it as an infusion or something, okay? So that was what he failed to do. He failed to have the requisite knowledge and to ask for help when he should have acted. So this particular registrar, regardless of how the patient turned out, needs training and retraining. He needs a slap on the wrist of some sort that would force him to learn a little bit more or to understand the gravity of what he almost did to the patient. Okay, so he would require some in-house punishment. Okay, perhaps extra calls or, maybe leave days taken away or something, okay? Whatever the institution deems fit to give him, okay? And aside that, he needs to have a process of training and retraining. So you would have to gather all the registrars and find out and train them on how to use fusemide properly. And of course, the pharmacokinetics and pharmacodynamics behind it, and understanding the side effects and adverse drug reactions from the dosage that we give our patients. Then I would also want to agree with Dr. Florence on the first investigation to do. I would most likely want to run an EUCR, although that takes time to come out, okay? But that will tell us about the electrolyte imbalances that may have been caused by the overdose of or the excessive dose of Lasix given to this particular patient. Also, what will have helped is perhaps an ECG. Okay. Yes, bearing in mind the patient is in heart failure. the ECG may not be very helpful, but electrolyte abnormalities could be seen early on ECGs, and that may give you an idea of what may be going on with this particular patient as well. So that may be something you may want to do immediately as well. Yeah, but the speaker has spoken very well. So well done. Yes, Dr. Remigos, your hand is up.
Yes, Chief. Thank you for the comment and contribution. Well, I want to slightly look at it from two different angles. The first angle is that of one, was it really the right diagnosis? Two, the dose that he gave, was that the problem? Can you hear me?
Yes, sir.
All right. So now, whatever happens or whatever happened, I think the recommendation is for the registrar to face a disciplinary committee where he would have to give his own side of the story. Okay, so he has to give his own side of the story. I don't think it's right to just go ahead and start recommending punishments. Okay, so he has to face a disciplinary committee where he gives his own side of the story. For example, it could have done what he did from experience. Maybe he had noticed that the doses of the particular furosemide that he's been using in that particular environment, that particular type, for example, that he needed higher doses to achieve something. And that's why he actually gave the high doses of the furosemide, okay? Again, sometimes you might think, because there are a lot of differentials. Yes, the presentation seemed like acute heart failure, but there are still important differentials there that could present similarly. Could it be something else? Okay, so, but let's assume it's heart failure, okay, and the problem is the dosing. Now, yes, I would agree that the next thing, especially if we are thinking about side effects of medication, I think is EUCR actually that should be done. And Chief Shitu, because you are in Nigeria, that's why you are saying it takes time. EUCR should not take any time. Within 5 minutes, EUCR should be ready.
No,
within minutes.
I agree. I've been in a hospital in Lagos where you can get point of care. It's minutes. It comes out. But
exactly.
If we're looking at it in the context of an exam done in this side of the world,
it doesn't matter. It doesn't matter.
You also have to say that as well. Because the examiners would say it in the context of what we have available in most centers. So you have to say, yes, I would love to do this, but this may take some time.
I think what one can do is say EUCR. But if they frown at it, maybe you can now think of something else. All right. But the most important point I wanted to raise is that there should be a disciplinary committee that the registrar should face and given an opportunity to defend himself. So you can recommend that. It's not that immediately you start recommending punishments. And then, of course, if you think the problem is a knowledge gap.
Dr. Remigos, do you think this problem should be sorted out hospital-wide or departmentally? That's where the issue comes in. Is it a departmental problem? Or do you think it's something?
It could be done departmentally. Yeah, it could be done departmentally.
If it's done
actually,
departmentally,
it could be done departmentally.
Yes. Then all that will happen is this. The immediate consultant will discuss with him and find out the issues around it. And then, of course, now perhaps during the next departmental meeting, discuss it at it and then sort it out. So there may not be an actual panel per se. But it may be something that will be discussed.
I think I agree with that. Yes, but my actual point is that he should be allowed to explain himself, should be given the chance to explain himself, to defend himself.
Definitely. We need to understand the context in which he gave it and how he went about it before doing anything.
When we now see the knowledge gap, we now know how to fill it. Thank you.
Thank you so much, Sam. Ma Christabel. Hello, ma.
Hello.
Hello.
Oh, yes. Dr.
Please,
Afekeme, please go ahead.
okay, please, I just wanted to make a response to what Dr. Shito and Dr. Remigo said. If the relatives want to take action, can it still really be handled intradepartmentally if the relatives are thinking of taking, I think then it goes above the department.
If the relative wants to wade into, actually raise a problem, they won't raise it in the department. They'll raise it with the hospital management. And that means it has not become a hospital problem.
Yes.
So that's why a panel must happen and all of that. But when you see, like it has happened, I'm sure many of us here have seen it before. Somebody, a young registrar comes in, makes an error in prescription, or his prescription is misunderstood by the administrating nurse or something, and then there are issues, okay? As long as it doesn't become a hospital-wide problem, it's something that can be sorted out within the department to sort out what the issues are. If the problem is the person registered handwriting, for instance, you tell the person, perhaps you should write in capital letters only and things like that so people can see what you write. And, something that can be sorted out within the department. But once it becomes a problem of litigation, it has become a hospital problem. And that has to be managed on the level of the hospital and then things like that. Now, in issues like this, unless he broke, if, for instance, in this same context, what he did was that he did not inform the seniors, okay? He went against the seniors' recommendations, okay? And the seniors feel aggrieved about it, then he has done two things, okay? Insubordination and, of course, putting the patient at danger. So, yes, he can be reported to the hospital, to the medical advisory committee chairman, and then they take it on from there. Things like that, yes. But in a matter of like this, that was salvaged and the patient got better or something of sort, let's assume the patient didn't die. Yes, it's something that can be sorted out within the department. It may not have to escalate the hospital-wide issue, unless it is something the person has been doing over and over and over again. Then yes, he may have to be taken up to the hospital because the hospital is his employer. And if you are not satisfied with his service, then you can hand him over back to the hospital to decide whether he stays or goes. Yeah. But I just feel that it's an error of knowledge. And an error of knowledge does not really require a hospital-wide panel or anything. What you have to do is figure out what he did, what was he thinking, and then try and sort it out within that context, within the department. However, if it escalates to the hospital level, then it needs a proper panel to sort it out.
All right. So, Dr. Shitu, there's this part of the question that says that the relatives were unhappy and were thinking of taking the patient out of the hospital. Okay.
If it has gotten to that point, then yeah, it has become a hospital problem. Disciplinary committee.
Yeah, and how about at that particular point in time, what do? You're supposed to, as a consultant, I think at least one should try and should I say reassure or talk to the patient relatives and then tell them that you take charge now,
but
like that.
You actually start with that, but you have to inform the hospital advisory medical advisory committee, either through the deputy or the chairman itself, okay, that this issue is on ground. So if they do escalate it, the hospital is prepared. Now, if you kept it to yourself and you're trying to, sort out things locally, right, and you see that and the thing doesn't go according to plan, and eventually they escalate it, they may hold you liable that why didn't you inform us on time about this thing happening? Okay, you may try and solve it departmentally, yes, but once the patient starts talking about informing the hospital management, it's better you let them know, give them a heads up. I'm managing the thing locally. However, they want to do this. Okay, and then if the medical advisory committee feel that the offense of the registrar is enough to set up a panel, even though they have not escalated it, then they will go ahead and sort that out. But you have to inform the management about aggrieved patients. You have to. You can't keep it to yourself.
Okay. Thank you for that. I also wanted to point out something. When the presenter was discussing, I think she mentioned something about clinical audit. I don't think you use clinical audit for a one-off incident like this. Okay, so usually it's maybe a repeated incident or something that you have noted, a particular
Or
statistic that you
multiple
want to change
registrars are
about the
doing the
hospital.
same thing.
So a one-off incident might not be an indication for clinical audit. Thank you.
I think what I know, she was looking at a situation of sorting the problem out on a larger scale. But in this type of scenario, that is a one-off thing. A clinical meeting or discussing it in a morbidity or mortality meeting may suffice in sorting out the problem. That way, people can come in and talk about how this issue should have been, or the issues that came up that led to this problem, and then how it could have been remedied or prevented in the first place, and things like that. Even the patient's diagnosis, if it was in doubt, will be sorted out in that meeting. So that way, everybody learns from it. So in case there are other people that have the same mindset, they would also, be put right by having that type of meeting.
Yes, thank you.
Yes.
Hello, sir. Okay, I just want to add on to what Chief Remigo said. I think also the patient can actually be reassured, because looking at the patient hasn't even been treated for the heart failure. So the heart failure regimen has not been recommended for this patient. So I think the patient can be reassured that he will get better. As in the relatives can be reassured that the patient will get better, because the main medication has not even been commenced on this patient. So I think the patient can be reassured that proper treatment to be given to them. So that's just what I think, just like what Dr. Chief Remigo said, that we can reassure them and letting them go. Thank you.
Thank you. Thank you, Dr. Kalabama. Thank you, Dr. Chito and Dr. Remigus and the presenter. Thank you so much. I love the way the presenter did her job. She has this wonderful storytelling ability, made the discussion quite interesting, even when our time was up. So it's a blessing. We appreciate your effort. There've been quite a lot of discussion on this already. So we appreciate the participation, the questions, the comments. Thank you. Dr. Keller, I think we should move to the next topic. It's almost 7:40. The next presenter,
All right,
please.
Sorry, Dr.
Right.
Christopher. Hello?
Yes.
If it's possible, I wouldn't mind someone that was in the exam. Oh, sorry. Someone
We do that after the end of the discussion.
that actually participated.
All right.
Dr. Keller,
Thank you so
please,
much.
the next presenter.
All right. Thank you, Ma. Thank you so much, sir. Thank you, Dr. Blessing, and everyone. Okay, Dr. Joffrey, please, and Dr. Bimpi. Hello, Dr. Joffrey.
Yes, please. I'm trying to share my slides.
All right. Thank you, sir.
Good morning, our teachers and colleagues. My name is Dr. Katubo, and I'm taking practice question 5. So the question is, a scenario of a 32-year-old patient with sickle cell anemia with a steady state PCV of 17%. Patient has been regular on clinic follow-up, but not regular on her medication, hydroxycarbamide. Between her last visit and this visit, she has lost about 8 kg. There are no changes in her biochemical and hematological results. Now, abdominal ultrasound scan done showed gallstones. It was a printed scan showing the liver, distended gallbladder, and stones for you to identify, not a report. Talk to the patient about the implications of her test. The simulator with me is Dr. Adebimpe. So I'm going ahead with it. Madam, good morning.
Good morning, sir.
Yeah, my name is Dr. Okatubo. I'm a member of your team, and I've come here to have a discussion with you regarding your illness and some of the test results we've had.
Okay, thank
you. Is that okay by you?
Yeah, that's okay. Thank you.
Okay. So, madam, because you have sickle cell anemia, there's an increased breakdown of your blood cells that is more than what usually happens. In a normal person, in any other person, it takes about 120 days before your blood cells break down. But for you, because you have sickle cell anemia, yours takes about 10 to 20 days. And we just checked your blood level and found out that you have a PCV of 17%. And secondly, even though you've been coming to the hospital regularly, we've just observed that you have not been taking one of your very important drugs, hydroxycarbamide. This drug actually helps to increase your chances of your blood cells not being broken down because it brings up what we call hemoglobin F, which increases the lifespan of your blood levels. And we have also noticed that you lost 8 kilograms between the last time you are here and now. So all this goes to show that there's an increased breakdown of your blood cells. And because of that, when there's an increased breakdown of the blood cells, there's something called bilirubin in your body, which now accumulates. And this accumulates in your gallbladder to form what we call gallstones. And these gallstones are hard, rock-like structures. The gallbladder is a small green pouch structure under the undersurface of your liver. And when these gallstones form, there might be no problem for most times. People don't have any problems with that, but sometimes complications will arise. And when these complications arise, you will have a right-sided abdominal pain, upper abdominal pain, vomiting, fever, and nausea. And you feel like vomiting, and you sometimes may need to you may even have to vomit. In such cases, we'll go ahead and carry out an operation to remove the gallbladder. But for you now, you don't seem to have these complications. So we have two options. The first option is we watch and wait and see if we are going to develop any complications, in which case we go ahead and remove it. Then the second option is that we go ahead right now when you don't have any complications and remove the gallbladder so that the complications will not come at all. But of course, we have to meet as a team. We meet with our surgeons, the anesthetists, the nurses, and others, and take a final decision on any of these two options we are going to take. But I'll add to you that removing this gallbladder will not really cause you further problems because the gallbladder is just a pouch, which, just serves as a store of what we call bile acids. So even if it is removed, the liver, which produces this bile, which is responsible for digestion of your fatty food, will still produce the bile which goes into the small intestine and still digest your fatty food. So there will be no problem about that. So I want to conclude that there are three major things. One, now your blood level is very low, and we'll have to do something about that. We'll have to give you blood or give you drugs to increase your blood level. Second thing is you have not been taking your drugs, which are very important in your condition. And I will have to discuss further on that, on how we are going to make sure you get your drugs. If it's funds, we'll think about raising funds to assist you in doing that. Then finally, you have these gallstones in your gallbladder. Our team will have a meeting and discuss whether or not we take the decision of having it out now or wait later until you have any form of complications. However, the ultimate decision depends on you. Thank you. Do you have any questions for me?
Okay, thank you very much. As regards my PCV of 17%, my blood level has always been that low, and there has been no reason for transfusion. So I don't know why you want me to be transfused at this particular point in time.
Okay, if you remember, I said there are a number of actions we might take about that, whether transfuse you or give you some other drugs. But the truth is, the normal range for people like you should be about 20 to 30%. And if at 17 you have any further episodes of hemolysis, that breakdown of your cells, it will tilt you into so many other problems. For instance, heart failure and some other things. So we want to prevent a situation where we get to that level. And the fact that, of course, the past for the past period, we haven't seen you. You had a loss of 8 kg. We don't know what is happening. We want to be on the safer side and make sure you don't break down. So that's why I'm thinking that your steady state PCV, which you have now, should be increased to at least 20%.
Okay.
Thank
So
you.
as regards this medication, nobody really explains why I need to take this drug. Can you please explain and break it down into detail why I have to be on this drug? Why do I have to take this drug every day?
Okay. So you have to take this drug called hydroxycarbamide because it increases what we call the HbF. That's hemoglobin F, which is usually seen in the fetus. And when that increases in your blood level, it gives a lesser chance of you having your blood cells being broken down. And when your blood cells are not broken down that way, then it means you have more blood, your blood level will rise more than what it is now. And there's a less likely chance that you are going to have a crisis. So that drug increases HbF and prevents your blood cells, increases your blood level and prevents your blood cells from being broken down. I hope you get me.
Okay. Then I think the reason I lost weight
If you have
is
2 more minutes.
because I've been having this abdominal pain and I've not been
1
feeding
minute
well
more.
because of the pain. So I think that's why I lost that amount of weight. Do you think it's related
Okay,
to what happened on the ultrasound?
Yes, of course. If you remember, as I told you earlier, that if you start having pains, then it means you are developing complications from the gallstones which had come up. And once that happens, we are most likely going to go for an operative procedure to remove your gallbladder. Thank you. Can I please just rush through this?
Okay, Chief, okay, I think we have to, I don't know, I think we have to talk about the conversation first before he goes on, or should he go on representation?
I think I want to beg the indulgence of the class, okay? I know we're pressed for time, Dr. Christabel. I know we're pressed for time, but I'm not quite happy with the counseling session. All right? I want to switch it and become the simulator. Dr. Christabel, would you indulge me for a few minutes?
Go ahead.
Hello, Dr. Christabel, are you there?
Go ahead.
Okay, all right. So, presenter, sorry. Can we just run through the whole thing? Let's leave the early peasantry, okay? And then let's go into the main thing, okay?
Okay.
Hello?
Yes, please.
So forget setting the scene, forget introductions. I'm sitting down in front of you. Oh yeah, just get to the main part and let's start. Please, we shouldn't spend more than 5 minutes. Someone should time
Okay.
so that.
Okay, yeah. 5 minutes.
Okay, so, okay, you want me to
So
start from the beginning again, please?
Yes, from the beginning again. But I am the simulator.
Okay. So good morning, sir. My name is Okatbo, and I'm here to discuss some of the results that we've gotten concerning your ill health. Well, you know you have sickle cell anemia, and this is a condition
Oga,
Yeah.
I don't understand English like that. I beg, speak broken English, I beg.
Okay. Your sickness is such that your blood cells, your blood cells break down.
Oga, waiting be blood cells.
Chief, this one is different.
Hello?
It's hello?
Hello, I'm with you. I don't understand what they talk about red blood cell. I don't know waiting be that.
It becomes very difficult for one to know any other word to use apart from blood cells.
There are many things you can say. Many things. You can say, Oga, you know your blood is red, Abi? Yes. You get something where they inside that blood where they make it red. And the work of that thing, that they carry the things where the cells they use to do their work. Do you understand?
Yeah, I do.
Now, you know why I'm speaking broken English to you now, ba?
Yes.
Too many technical languages. So now break it down. I want a market woman to understand you.
Dr. Shitu, I need to be sure that he knows. Dr. Katsuko, do you know why he's using broken?
Okay, so that the patient might not be educated and will be able to understand broken better.
Apart from that, the idea is to make your explanation as simple as possible that a market woman will be able to understand it, regardless of the person's educational status.
Okay.
So can we proceed now?
Okay. Okay. So you know, say this sickness when you get. Now, one sickness when we say that's waiting there your blood, they cause something when we say every time the blood, your blood, they finish quickly. And now because of say the kind thing when they your blood, they make and they break down, they break down quickly more than every other person own. Your own blood, they stay for only 10 to 20 days. But other people own, they take for up to 120 days. And because of, say, the thing they break down quickly like that, we give you one medicine. When we say, because of that medicine, your blood no go dey break that quickly like that, and you will get more blood inside your body. But somehow you no fit dey take that medicine. We will want to know why you never fit dey take that medicine. Na money or na just because you no fit you no fit buy am?
Now because money no today and that drug, I don't even like how it tastes. And sometimes, but nothing they do me now. I feel all right now. So I know they feel like I need to take the drug because my body don't feel.
Hello, sir. It's been 5 minutes now. I don't know. You want to?
Okay. All right. I just wanted to do that, right? I don't want to waste too much time because we don't have time on our side. Okay. Now, the reason why I brought the presenter back is that, please, when we are counseling a patient, we have patients in clinic, we counsel them. How many of them do we talk to like this? The examiners know. We know that that's not how we talk to our patients normally. They want you to break things down, make things simple, make things easy for the patient. Okay? You know, rather than using, you can give examples rather than just saying the things directly. Okay? Oh, red blood cells are broken down and then the products are blocking one place. You could talk, say, look, red blood cells, or the things that carry things, the nutrients that the body needs up and down. We call them red blood cells. These things, they don't last forever. They get broken down at some point and then new ones have to come into play. Now, what is happening in this patient is that it's being broken down quickly, okay? And the new ones are coming up, and those new ones too are not staying for long. Now, imagine if you buy a land with a house already on it, okay? And you want to build a new house. What will you do? You have to break down the old house. And every time you break down the old house, you have what? You have a mess to pick up, right? There'll be cement everywhere. There'll be broken tiles, broken everything because you've broken down the house. Now, for you to be able to build on that land, you must pack all those debris away, all the broken cement and everything. You must carry them away. And wait, what to carry them away? Trailers will come and carry them. Abi, the person will tell you yes. Okay, now if this trailer is going on the road and the trailer runs out of petrol or it breaks down, okay, what will the trailer do to a small road if it breaks down on it? It will block the road. And then what happens? You cannot pack more of those things coming out, Abi? And of course, it blocks the road for other people that are also trying to do the same thing. And in the end, you have a bottleneck at that point. Very simple, straightforward. If it's a woman, you can use the kitchen to describe it. Oh, if you're washing things down the sink, right? And you don't, clear the more solid particles and you allow them to wash down the sink, what will happen? The sink will get blocked. And if the sink gets blocked, it won't allow water to flow. And what will happen to the sink? The sink will start to accumulate water. It will not flow. And the sink cannot do the work it should do. And things like that. So you can use simple examples like this to describe clinical scenarios like cholestasis and stuff like that without having to use large, ambiguous terms to describe it. Try and keep your discussions as simple and as clear as possible. My trainers back in the day will tell me, look, Shitu, when you're saying these things, say it such that your daughter that is there, my daughter was what, 5, 6 years old, would be able to understand you if you're describing it to her. Or a market woman will come to your office and be able to understand you when you're explaining it to her. And that's how they want you to keep it simple. There's actually marks for keeping it simple. Do you understand? That's what I just wanted to point out from what I pointed out. And then please, if a person is not using a drug, try and find out the reasons why. You found it out with me, but with your original person you were counseling, you didn't find out why the person was not using the drug. Okay? And then also, the fact that the person was losing weight already from the cholestasis, right, shows you that the person is already symptomatic, means that the person may need a consult with a what? With a surgeon. Okay? You don't have to start, you can say, okay, the surgeons may decide to watch it for a while, or the surgeons may decide to remove it, okay? But they will be the ones to take that decision, okay? But always try and be multidisciplinary in your action, so that way you don't have to start explaining things that are not necessary. Oh, we may have to book you with the surgeons to see this, and sort this out. Then it's important to find out the person's steady state PCV, okay? And you don't have to use terms like PCV. Have they measured your blood before? Say, yes. So which kind of value did they get? You get one value, be like percentage, be like phone battery. Everybody own different. Okay? Some people, when they charge their phone onto phone battery, it reach so place. Maybe till it reach 17 or till it reach 15 before they charge them. You, where your own they go to before they begin tell you, say you need to do this or do this or do this. When you describe it like that, the person gets it, and then the person will tell you, oh, this is my steady state. And if the person is within a steady state, fine. And steady state is not a range, it's peculiar for everybody. That's why the management of sickle cell, they say it is individualized. Okay? So those are the other things I want to point out. Because of time, I can't really go so deep. So, but well done.
Thank you.
A lot of things. And I like your calm discussion with the patient. Okay, although your simulator was nice, okay, but if you meet a restive simulator, you may not, your calmness may be shaking a little. All right, so thank you.
Thank you, Chief.
Yes. Sorry, over to you. If there are questions, clarifications, or anything, I think.
Remigi's hand is up. We don't have too much time again, Chief Chito. We have to. Okay. It's already past. Right. I think it will soon be past 8. A lot of other activities taking place at about this time too. So, Chief Remigo, just give him that opportunity and let's close the class, please.
All right, thank you, Dr. Christopher. Well done, Dr. Casper, for the presentation. I'm happy you presented. Okay, so at least now you are already beginning to see some of the issues or some of the flaws. That you may have. You need to put that out of your mind. Remember that it is not the examiners that you are trying to impress. What you are trying to do is to educate the patient, to communicate with the person in front of you. Okay, so your key or your focus should be on the patient or your client and not whether the examiners think you know stuff or not. No, please just take that out of your mind right now. Okay, so now, yes, so your primary purpose or your primary assignment is to communicate with this person, to make your patient understand what the problems are, what the situation is, all right? So that they will be better. Their health will be improved. They will have a better health-seeking behavior. Apparently, from the scenario, the problems are basically from her end, all right? So she needs to understand so that she will improve her behavior towards her health, and then everybody will be happy, okay? So now, one very key issue that I had with you was you didn't follow the normal protocols. You didn't, the setting was not well done. And then I didn't see you communicating with empathy to her. And you weren't even giving her time to assimilate what you were trying to say. Now, you are supposed to have found out what she knows, her perception about the condition, what the problems are from her, even before you start giving her information. Okay? So, but you just dug right in and started throwing information at her. You weren't even interested in whether she was getting what you were telling her or not. No. Before you finish your discussion, you should have allowed her to recap what you said at least 2 to 3 times. Okay, so when you give the information in piecemeals if you want her to understand it. Remember, she's not a doctor like you. Okay, neither is she a health personnel. She doesn't understand all the big terms. That's why she to have to take you down to that level so that you understand that the people that you are talking to might not even know a single thing about, even red, you might not even know what red is. You might have to start explaining what red is. It can be that bad. Talk less of red blood cell. Okay, so you need to make sure that the person is following you at every point in time. When you give the initial information, you ask, do you understand what I said? Can you recap? Do you have questions about this so far? Okay, I'm sorry that this condition has, you need to put those empathetic words when you're talking to her. Okay, you're not judgmental, you're not judging her, you're not a prophet of doom, or you are someone that has come to help her. And then please don't say people like you. It was so, I was shocked when I heard that. People like you. What does that even mean? How can you say people like you? What are people like her or him? Who are people like her? Please don't say that. You can say something like, people that have this kind of condition that you have, you understand, it's better than say people like you. In fact, that was almost insultive. All right. So please, you have to learn the right words to use. And then remember that at the end of the day, whatever it is you want to do for the patient depends entirely on the patient. When you were talking about consulting with other people to decide what to do for her, even though at the end of the day, you kind of corrected and said the final decision lies on you, fine. But when you were talking about consulting with other people to decide what to do for her, it was looking as if we are being paternalistic and all that. So remember, it's patient-centered care, all right? Always remember, in fact, spikes can work for most things, not only breaking bad news. Even in a counseling station, even spikes can work too, all right? You can use that model in a normal counseling session. Because truly, you're even breaking bad news here, because we're trying to tell her that she might need surgery for gallbladder stones. This is breaking bad news. Okay? So you can use the spikes model, if you remember the spikes model. So please, I like the fact that you presented. It really showed us that you still have a long way to go. In fact, if you look at the comments, people were saying, oh, beautifully delivered lecture. You're not supposed to be lecturing. You're supposed to be counseling. You're supposed to be educating. You're supposed to be communicating. Okay? So I think I'll stop there so that I will not take too much of our time. Thanks so much.
Thank you, Chief.
Thank you, Dr. Jeffrey. I'm going to Chito. We appreciate the comment. Well, we have to close the class now because of the time. Thank you so much, our facilitators, the presenter. Thank you all. I think Dr. Chito, Dr. Remgus already highlighted all I will have to say. So please, I must commend you for one thing. At least you got a simulator. I really must appreciate you for being proactive. Please, from your actions, it shows that in a way you've not really be counseling your patients, because really, if you have, it will show. So please, want to encourage to keep practicing. That's how I encourage our participants to keep talking, keep practicing. Is in doing some of these things, your limitations will be noticed and it will be worked on. So if you have not noticed you have a limitation, or if you yourself have not noticed you have a limitation, you might feel you are fine, and you go for the exam and they'll just mess you up there. So please, Dr. Katubo, we appreciate you, but want to encourage you to keep speaking up in the exam and keep practicing with your live patient in your clinic, in the ward, wherever you are with your patient. Keep counseling your patient, really. If you are the one that counsels your patient, it actually shows in exam. I tell people this exam is passable. It's what you do every day. You don't need to cram. Use your patient, just do the right things with your patient. And once you go for your exam, it just be easy peasy, because these are things you do naturally. It's like it's a second nature to you. So it's not be like you're cramming. It's not be anything. You just ease into your natural environment of counseling your patients. We want to encourage our participants to keep practicing, to keep talking. Our uncles, Dr. Ekele, Dr. Kalamama, thank you so much. Our participants, those that are active, we say thank you. Keep being active. Those that are inactive, we want to encourage you to be active. Thank you so much. Chief Chitu, sir, just a comment.
Thank you.
Hello, ma.
Okay, yes,
Chief
it's
Christopher,
true. I forgot because of the time. The time is clashing with my own. I have other meetings currently. Let me